Hi, doctors. Good evening. I'm Dr. Hanish from OneRx, and thank you for joining today. And thank you for joining today, Dr. Mohit Makar and Dr. Aditya Ambesh. And thank you for joining Dr. Rajesh and Dr. Swaroop. And thank you for joining Dr. Princey, Dr. Neeraj. The session will start by 7:30. We'll wait for other doctors. Most of the participants will be joining. We'll wait for more 5 more minutes. Meanwhile, can I know more about Dr. Aditya Ambesh? Where are you from? Yeah. Hi, Dr. Aditya.
I'm a senior resident in Dr. Raman Hospital, Radiation
Okay.
Oncology in Lucknow.
And have you installed OneRx app?
Yes, I've installed, but I've not opened it and not
Okay.
used it yet.
So in this session, after the case discussion, we will show all the features which is available in OneRx and how it will be useful in your clinical workflow.
Yes, I'll be looking forward to it. Thank you.
And thank you for joining Dr. Manchula and Dr. Prabhanshu Thakore. Thank you for joining today. And Dr. Neeraj Dingra, thank you for joining. And Dr. Princey and Dr. Karishma Agarwal, thank you for joining, ma'am. And Dr. Sumit Kumar, thank you for joining today. And Dr. Swarup R, thank you for joining. I can see here device names OnePlus. And thank you for joining Dr. Meenakshi. And thank you for joining Dr. Nilesh Tiwari. Thank you, sir. Thank you for joining today.
Thanks.
And thank you for, yeah,
How long is the session plan? Just want to know.
1 hour,
Okay.
7:30 to 8:30. So, still 2 more minutes. Let's all the participants let get joined. And thank you, Dr. Sankalp Naidu, for joining this session. Thank you so much. And thank you for joining Dr. Ajay Babu. Can I know where you are from, sir? And Dr. Nilesh Mani, thank you for joining. Dr. Sumit Kumar, thank you for joining today. Dr. Prabha Verma, thank you for joining today. Hi, Dr. Dhirendra, thank you for joining today. And Dr. Venkata Hemant, thank you for joining today. Can I know where are you from?
Hello, I'm from Bhopal.
Okay,
Name's Bhopal.
AIIMS Bhopal. Thank you for joining today. And thank you for joining Dr. Divya. Thank you for joining today's session by Dr. Riya Kumari, Dr. Rajesh Balakrishnan, Dr. Priyadarshini, Dr. Nishta, Dr. Nishant Prabhakar, Dr. Sanjeev Sharma, Dr. Suchitra Upacharla, Dr. Nitin, Dr. Manish, Dr. Agni. Thank you for joining.
Dr. Anis, I think we have the room. We can start now.
Good evening, everyone. A very warm welcome to today's CME session, Evidence Rounds by OneRx. I'm Dr. S. Hanish, Medical Advisor in Oncology and Hematology at OneRx. I will be moderating today's discussion. It is a pleasure to welcome our esteemed faculty for today's session, Dr. Rajesh Pasricha, Radiation Oncologist from AIIMS Bhopal, and Dr. Sankalp Naidu, Radiation Oncologist from MNJ Cancer Institute, Hyderabad. Thank you, doctors, for joining us today. I would also like to welcome the OneRx leadership and medical affairs team joining today, Mr. Vivek Steria, CEO and founder of OneRx, Dr. Suchitra from Medical Affairs, and Mr. Sanjay Maurya, Business Head. So the idea behind evidence rounds is to create a practical, case-based academic discussion where we connect the latest evidence, latest guidelines, and real-world oncologic practice. So today's session is not just about data, but about how that evidence translates into day-to-day treatment decision for our patients. So once again, thank you for all joining. Let us begin today's evidence round. So before begin with the case discussion, I would like to introduce OneRx, a medical AI platform which is built for doctors, powered by Medical IQ Layer. So OneRx helps clinicians access evidence, guidelines, trial data, and treatment insights at the point of care. So let us take a short look of OneRx. So today we have almost 1,400 oncologists are using OneRx for quick evidence summaries at the point of care. So OneRx helps with second opinions, trial comparisons, treatment guidelines, intelligence, cost considerations, and Indian practice context. When it comes to data, so our data sources include medically trusted platforms like NCCN, ESMO, ASCO, Lancet, PubMed, and other journals. And you can see these are the journals we have built with this platform. And when it comes to data privacy, so it is a zero data storage. So OneRx does not store patient records, diagnostics, or any identifiable information. So this data is processed in real time and discard no collection, no secondary use, no third party sharing. We have ISO certified, SOC 2 compliant, DPDP, and HIPAA compliance. So now we are giving for all the users who have registered as promised for lifetime access. You can install this app. If you are not installed, you can use this refer code RP01. So we will pause for 2 minutes. If any users you are not installed, you can install right now. So now we move to the most important part of today's evidence rounds, the case discussion. So the idea is to keep this very practical, how we interpret the evidence. So I would now like to hand over the discussion to our expert faculty, Dr. Rajesh and Dr. Sankalp Naidu. Over to you, sir.
On behalf of OneRx, I welcome all my colleagues, juniors, students in this very important session. We all know that AI has now become almost part of our life, and almost everybody uses ChatGPT, Gemini. Am I audible?
Yes, sir, you're audible.
So everybody of us using these large language models, which are general models. So being a doctor, we have used them. We have seen that they make a lot of mistakes, a lot of hallucination happens. So this is because they are trained on a very large model, and medical data is just a small part of it. So what OneRx is there, it's platform which has specially been trained on the medical data and trusted medical sources like as NEGM, NCCN guidelines, ICMR guidelines. So this gives us a better answer for medical queries which are evidence based, and it hallucinates very less. And I have once I've seen I have started using it, and I find it very convenient, very accurate, and just on our fingertip in our mobile it is there, and we can use it immediately as soon as we see the patient. We can ask our queries, and it gives you immediate update of the data. We all know the medical data is comes at a very fast pace, especially in oncology. Every day new trials come, every day new information comes, and it becomes very difficult for us to keep it up with the information. But here the OneRx comes into the play. It summarizes the information, gives the latest evidence, and which we can use for our patients' benefit. So thanks OneRx, and I think we can start the case now. Can I share? Can I see the case? Like sharing the it is there, I think, in my uh, uh, case. I think, Hanish, can you start the case from your end?
Sure, sir. Just a second.
So because something is,
Okay.
or let me check if it is there in my laptop. Can you enlarge it a bit? Yeah.
Yes.
So the first case is very interesting, and it's a rare case. Uh, Rare both in terms of the disease as well as the treatment. Skull-based chordoma, we see that not that frequently, but we do see one or two cases in a year. And we all know the best treatment for chordoma is proton radiotherapy. So let us start with the case with this background. Patient was a 46-year-old male, a resident of Hyderabad, and he was a software engineer. That means very well educated, and he had controlled hypertension and ECOG status 1. He presented with progressive double vision, facial numbness, headache, and difficulty in swallowing, with worsening vision in the left eye. Early 5 years back, he was diagnosed with a clival carcinoma, and he had undergone subtotal nasal endoscopic resection. At that time, the post-op images showed residual disease, which was very close to brainstem. That is why he opted for high-dose proton radiotherapy, because we all know proton is a very sharp fall-off, and that is the best modality to spare the adjoining brainstem. Total dose was given was 74 Gy RBE, in 37 fraction to the residual tumor. And brain received almost full tolerance of 54 gray at that time. And also optic chiasm received full dose, 52 gray, almost full dose. He was well for 4 years, but recently when a new MR scan was done as a follow-up, it showed a 4.8 by 4.2 by 3.9 centimeter lobulated recurrent mass in the clivus, which was extending into the left cavernous sinus, prepontine cistern, and also it was encasing the internal carotid artery. That means it was inoperable, and it was compressing the pons and the brainstem. Externally, it was the extension was there up till optic chiasm also, and inferiorly it was going in nasopharynx, uh, and there was no hydrocephalus. So with this problem, he presented this thing, and a CT was also done, which showed extensive destruction in the clivus and the left petrous apex with cortical breach, and there was no pathological fracture of the clivus. Sandostatin receptor PET CT was done, which showed intense uptake in the base skull lesion, and there was no distant metastatic spread. Again, endoscopic biopsy was done, which confirmed that it is a recurrent chordoma, which was brachyury positive, cytokeratin positive, S100 positive, and Ki67 index was almost 12%. That means it was not very proliferative, on kind of benign. And there was no definite dedifferentiated component in the case. So the clinical challenge we all know is for a multidisciplinary team is that the recurrent tumor at a very critical size site, and which is very difficult to resect surgically because of previous radiation, and also because of the location. And how do we go about it? And already patient has received very high dose of radiation, and almost the normal tissues have received almost the dose to full tolerance. Although there is a gap of 4 years, but still it will be a very daunting task to give radiation again, keeping the dose to the critical structures very low. So the discussion question is that how it will be. Is it safe? What is the safest effective salvageable strategy? It's surgery. Is it stereotactic re-irradiation? Again, can we use carbon ion re-irradiation with proton, or some systemic chemotherapy, or the newer agents? How will we control the, if we opt for re-irradiation with either stereotactic or maybe with protons, how will we control dose to the critical structures which has already been fired to full dose? So with this question, I'll invite my all of our people who have joined this important session. So I'll ask from all the oncologists present here, can anybody answer that what is the best treatment in this scenario for this particular case? All of you are welcome to join and give your opinion. I can see a lot of my students also there. So anybody? See, it's not a live class. Anybody can answer with. So I think one
Yeah,
should.
Dr. Sankalp, sir, I'm Dr. Sankalp. I'll answer it, sir.
Yeah, yeah, please,
So
please.
this is a case of a skull-based chordoma. Prior to 74 gray was given, it was
Correct.
a recurrent skull-based chordoma. Recurrent, it means that it has already been salvaged by surgery, probably. And what is the safest, most effective salvage strategy in this case? So we
Correct.
have options of repeat surgery,
Correct.
stereotactic re-radiation, or fractionated proton carbon ion re-radiation, or
Yes.
systemic therapy. So
Yes.
chordoma doesn't systemic therapy in chordoma is has much no value presently. So I would like to go for, if possible, a repeat surgery. If it is possible, I will take an opinion from the neurosurgeon whether he can go for the surgery or not. Or else I would go for stereotactic radiation. Either if I have proton in my hand, I go for proton again.
Sir, how will we control the dose to critical structure which have already
But
been
I will
fired?
go. I'll not go for higher doses.
Okay.
So
Okay. And
I'll try to
of course,
do some sort of stereotactic, sir.
suppose we have a carbon ion at our disposal, so will you consider carbon ion in that case?
Yeah.
So okay,
Yeah.
so
Carbon iron, obviously, sir, it has its own advantages. So obviously, if available, if I'm in Japan, and obviously, I would like to go for carbon as a fractionated
sure,
stereotactic carbon ion.
yes, great.
Yes.
So anybody else will like to give opinion, maybe a different opinion?
Yes, sir, I'm Dr. Nilesh.
Sure, please.
Since a patient has already received high dose radiation and 4 years has elapsed, so
Yes.
if we are first of all, if debulking surgery can be performed, then a neuro consultation should be done. Neurosurgery consultation should be done for debulking. And for re-irradiation, we have to see that 3 years have elapsed, and
It's
since we know 4 years have elapsed, and in 1 year, approx 30% of radiation recovery occurs. So in 3 years, 100. It is estimated that almost 100% recovery has been done. So we can again go up to higher dose. But while re-irradiation, we have to keep in mind that the BED should not exceed more than 120 gray equivalent, 120 EQD2 of up to 120 gray. And since of all the options available, carbon ion irradiation, if is feasible, then we should go for that, followed by proton, followed by stereotactic radiation. And
agreed, agreed. And
if some studies have also shown that immunotherapy can be used for indolent uh,
okay,
chordoma, like
okay.
PDGFR inhibitor or EGFR inhibitor.
Okay, so that's I think the house is for debulking surgery followed by de-irradiation with the carbon ion if available, or maybe stereotactic if not available, or maybe protons. But only caveat here for surgery is that the tumor is encasing the carotid vessels. You cannot, obviously you cannot excise it completely, but maybe we can debulk the tumor, which may increase the radiation effect of radiation. uh, Obviously the dose we cannot go beyond BED 100 as told by the previous speaker. So this is what is consensus. If anybody else have a different opinion, please come forward.
The surgery has, this is Dr. Rajesh.
Yes,
Surgery
sir.
has one more advantage. Maybe possibly can take a place a spacer also between the asm and keep it bit out.
Yes, sir.
One added advantage also. In case
Yes.
surgery is possible, that is always better, and then go for it. Maybe I will try to do fractionated thing more as an SBRT type, like 40-10 or something like that, rather than go for conventional fractionation, because you can reach up the RBE in a better way, in a safer way, rather than going for multiple fractions.
Yes, sir. Yes, sir. Very correctly said. So now, can we, Hanish, can you please show the evidence what you found on when you gave this case to OneRx? What did OneRx showed? So now it will be, see how that is what as a oncologist, a patient has come. This is what we will actually think when this kind of case comes. But when we give this question to this platform, let us see how good or how good the answer is.
Detected recurrent skull-based chordoma, searching latest evidence, guidelines.
So another thing
Yes.
I would like to add here is that since the evidence for proton is just coming in, and it's very sketchy and very difficult to get also. And like we said, we have a hunch that surgery may be correct, as it's a benign tumor from our traditional knowledge. But exact evidence, what is the exact evidence, that probably we may not get immediately. It is here this platform will be of great use. Immediately you'll get the evidence, level of evidence. So your answer is more, I think, supported by evidence and more confident because you know what the evidence is there. So can you scroll and show how it has given the answer? It has given everything. You can see where is the proton available, what is the cost, what are the salient features. Go a little slow. Go a little slow. I'll tell. So it has considered each and every factor what is there, like we were discussing about the tolerance doses, what is the normal dose, and how much has been prior dose has been given, And what is why proton is better, because it has a sharp bragg peak which will help to minimize those to critical structures. And also what is brachyury positive, this is again and what is the use of this kind of IHC markers, everything in detail it has given. In fact, you can even ask for a, this is a very, I will say, very large document. You can even ask for a short summary also to tell you to your patient, or even you can give it to your print and give it to your patients also. That also can be done. Yeah, means everything is there. So can you just Dr. Hanish, can you show what is the, what exact treatment it has told us, and on what and based on what evidence? So these are the, you can see everything it has given. Repeat surgery, what is the contraindication? Repeat stereotactic irradiation, what can be given? And so the consensus according to uh, the OneRx is that we can do a repeat surgical resection, but there is slight contraindication because of the carotid encasement. So debulking, yes, we can do. Stereotactic irradiation can be done because this is most easily available to all of us in India. Proton now has come. If available, proton will be a slightly better choice than stereotactic irradiation because of its back peak and low dose to the critical structures and sharp fall off. And among all the radiation modalities, best will be the carbon ion irradiation because it has got very high LET, superior RBE against the radio resistant tumor like Chordoma. So this is actually, this is what we were discussing. Yeah, this is what we all discussed. But good thing is that now the exact evidence for each and every modality is in front of us. So, Dr. Hanish, can you now, if there is any other case, can we take that? Or any of the people who are participating or oncologists, can they, if they have any case, that can also be taken up.
Yes. So, doctors, if you have any questions from your side, you can ask a challenging question to us, and we can put the same case here and showcase to you.
Yes. Any question, any case can be put in the chat and maybe we can see how it answers.
Yes.
Or any difficult query, any difficulty our colleagues are facing in oncology, or any doubt they have, they can we can right now check.
Hello.
Yeah, please.
Yes.
Yeah, I'm Dr. Minakshi. Hello, Dr. Rajesh.
I will actually.
Uh, so
Yeah.
I have a query.
Yeah.
Is there a role of any molecular testing like EGFR or mTOR and any trial or any evidence of it
Just in
in
fact,
the?
I also asked this question before when I was looking at the case. And
Uh-huh.
can you put this query?
Yes,
Any
follow-up question.
what
Uh,
molecular testing can be done and how it will be useful in this
okay, I'll
case?
just put it down.
Sure.
We have some questions in
Yes.
chat
Yes.
box, sir.
So Hanish, you one by one you can please start taking
Sure.
questions.
So, it is
See
evident
what
that
Dr.
role of
Meenakshi is
neutron has
about.
decreased.
Yes, yes, it's what Dr. Meenakshi queries results in. Everything it has given me what we can do, what Dr. Meenakshi was asking.
I will zoom the screen.
So even you are getting citations of the evidence. You can directly click out the citation, go to the original article if you wish to.
So, we got the answer: molecular testing in recurrent recurring positive skull-based Cardona.
Yes. So where it is available, that also it is telling. So
So, we
this,
got recommended molecular panel.
yeah, it is not recommended, but yes, as a last option you can do, because this is a case which is now there is no definitive treatment. It's only palliative case. So we can consider molecular testing, and if it comes to a positive, that will be good for the patient. If and drug can be used. In fact, I also checked for this question before the presentation.
Because certainly the resurgery and
Yes,
re-radiation will be very morbid for this
correct,
patient.
correct, 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 correct.
So we have to look for other options
Other
and
options also, and
uh,
if then can be. And nowadays, molecular testing with NGS has become so common everywhere.
Yeah,
So
it is
and
being
the
tested
chance of
everywhere.
yes, the chance should be given to the patient.
Yeah.
Correct. Hanish, take other start. Let us start taking other questions in the chat.
So another question, it is
Just
evident that
you can just copy paste
ro-
and put it here. Yeah.
okay.
First, we will
So
take the questions which are from which are related to this. I will say this case, and then we can take other questions.
sure. So in this case, there is a question. It is evident that role of neutron has decreased after advent of proton or carbon. But for sake of discussion, is there any role of BNCT?
We can just put this. We'll see what
Sure.
I frankly I don't personally I don't have any idea about this, and let us see what we learn from this.
And doctors, if you have any questions, you can put in chat box. So we will answer those questions.
Yeah, it is free for 1 year. Rest I think Hanish will tell you. There's one question which has come up for subscription thing. So it remains strictly investigational, plus not available in India. There's only phase 1-2 trial which is going on, maybe completed in June 2026. So you are now update about neutron therapy also. So let us come to the. These are the details which can be read if whosoever is interested. So it is an experimental therapy, all said and done. So
So there
what?
is another question, sir.
Yeah,
We can go for first, followed by surgery. What we can irradiate, rest we will operate.
just put. See, what I feel about this question is that already patient has been irradiated. You will re-irradiate, and then you do the surgery. It will be very, very difficult. A lot of fibrosis will be there. So if you have to do surgery, do it first. So this is what, as a oncologist, I will do. If surgery has to be given a chance, it has to be given before re-irradiation. So there's no point in doing surgery after irradiation because it will be very, very morbid. In fact, if there is any neurosurgeon, they can probably corroborate my answer. Can you just a bit slow? What is he saying about the sequencing? No, 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 not this one. Same. Yeah, yeah, this. Uh, little down, little bit down. Just can you move down? I just wanted to see what sequences is this telling for FSRT. Yeah, FSRT first will reduce the tumor volume, potentially convert border and resectable second surgery most of disease. Recurrence. Maybe I don't know. Theoretically, this may sound good, but if any neurosurgeon can tell better. So maybe my interpretation is not as per what the evidence is. So you can correct yourself also. There's no, I think, nothing in this that if we are not knowing any of the questions. So can we take other questions
I think so. These are the questions we got respect
for
to
this
this
case? Okay, let's start
case,
with
sir.
the, whatever other questions are there.
The questions, other questions we got regarding the platform. I will answer those questions
Sure.
uh, after this. Yes.
There is one a case of acral melanoma of lower foot just now. Queries come.
Case of acral. Okay, I'll put this case now.
Yeah, this acral melanoma. Can you check?
Yeah.
It's good for especially for the rare tumors because which we see very less and difficult to find evidence also.
So, a case of acral melanoma of the foot in lower limb that underwent wide local excision with sentinel lymph node biopsy, which was negative. And post-operative histopathology revealed a tumor size of 3 centimeter and no desmoplastic features and no perineural invasion. The anterior superior surgical margin was 0.5 centimeter. The patient cannot afford immunotherapy. Is there any role for adjuvant radiotherapy in view of the closed surgical margin? So this was the question, sir.
So adjuvant radiotherapy is indicated, and we need to do molecular profiling. It is even telling that whether the drug is available with the Ayushman or not. So, Hanish, I think now since you are providing this platform free for 1 year, so everybody can now put their queries, download this platform, put their queries, and get the answer. One more important feature, which I also find it very useful, is that you can directly upload the case summaries and ask about what to do. In fact, one of the cases open at my end also. If you want, I can share my screen and show you how I did it.
Sure.
So
I stop my
yeah, you
screen.
so I'll share, and then probably you can take all other questions.
Sure,
I'll
sir.
hand over to you after that. So I'll just share my screen. Uh, okay. Oh, it's not coming. Somewhat. Yeah, this is now it is come. So you can see I had two cases of breast, and you can add. This is first case which I uploaded, and you can see uh, entire everything it has given. So if I will show you the summary also, which I two cases which I uploaded, it is the case summaries. If I can open and show you this also. That I think something is going wrong. So, like these were the two cases which I uploaded, and I got the entire thing: what to do, what not to do. You can check also here also. What chemotherapy, what plan of radiotherapy, endocrine treatment, what critical, what we did, and what was the critical gap which should have been done. So why, what, in what trial this patient fit, and why it was not, what was the disparity, what we did and what was not there in this one. Everything is there, so you can even improve your practice. So everything it is given very beautifully in a table wise, what chemotherapy we gave, actual treatment we gave, what is the evidence, and what is the deviation, and how severe is the deviation. Similarly, for each and every part which we did, we can verify what we are doing is correct or not also. Radiotherapy plan was very good. It was fully concordant with NCCN because we gave the radiation. Chemo was given by medical oncologist, and surgery was done by surgeon. So most of the discrepancies here are in the systemic treatment only, and they are somewhere it is high also, and somewhere they are moderate discrepancies. So this is how you can even look into your own work, what you are doing. So I think this helps us quite a lot to improve our own practice also. So I think now I'll stop sharing my screen, and probably Hanish will take over.
Thank you, sir.
So Anish, I think is my screen visible still, or I've stopped
Yes,
sharing?
sir. It's still visible.
I don't see the option of closing it immediately. Uh,
It's closed now, sir.
Yeah,
I'll
I
share my
closed it for
screen.
you.
okay. I think now Hanish will tell some more benefits, and everybody. I must recommend that everybody should download this platform since it is free and very useful, much better than ChatGPT or Gemini because they are very general platforms. So Hanish, please over to you.
Yeah. Thank you so much, sir, for giving your clinical discussions and your thoughts and information regarding OneRx. So I will explain what are the features available in OneRx platform. So one is my cases, which is already shown by Dr. Rajesh. So I
Dr.
will show you in
Suchitra,
detail.
one question from Dr. Suchitra: from where is the evidence gathered? So this was shown in the as soon as we started the presentation. Harish, you can better answer this. Probably.
Sure. So where is the evidence gathered in this AI? So we have trained this model from NCCN, ESMO, ASCO for medical oncology. And in radiation oncology, we have trained with Astro guidelines. and surgical oncology SSO when it comes to literature sources. So we have almost all PubMed literatures, Lancet, JAMA, NEJM. So these are the trusted, reliable sources which we have for generating these answers. And also we are having FDA websites. So whenever any new molecule get updated in FDA, you will get as a notification as well as in the news section, which I will be showing in sooner now. So when it comes to my patient section, so here you can enter your patient name as well as enter the patient files. So what happened after entering the patient file? If you click the AI summary, we will get a master summary of the patient. So what immediate attention required for this patient? What is the whole summary of this patient case? And what are the lab values, abnormal and normal values with respect to this lab reports of this patient? And what missing information? So a patient is in provisional diagnosis. So for a doctor, he need to go for the final diagnosis. So what tests have to do for going for the final diagnosis? So here we got the AI summary, and then here we'll be having the add notes. So most of the information will be not in the patient report. For example, let's take comorbidities. A patient is the hypertension, diabetes, as well as the obesity. So this information is not in the patient profile. So here we'll get some of the regimens with respect to the patient. So here some information is missing. So now I'll be adding patient is hypertension on medications of, just take tell me certain. So here I'll be saving this information. Now I'll be asking what is the line of therapy. So here you can see, so the upload file you can see here as well as the my patient context. The patient is hypertension on medication of telmisartan. So this information, whole context of the patient is already loaded. So now it start analyzing the patient as well as the context of this patient which we have entered. Now it goes for the mapping of the guidelines, clinical guidelines, evidences, and of all the FDA drugs which is available. Now we will get the summarized answer with respect to this patient. So this is one of the future which we'll be having. And here, clinical trial match. So this is one of the future which we got enormous response from the oncologist. So let's think, a patient can't afford any chemo regimen because he'll be like a poverty. So in clinical trials, he'll be getting all the free treatments. So with no oncologist, he have to verify, is there any clinical trial match? Is there any clinical trial is ongoing? Everything with respect to this patient, matching the biomarkers, inclusive criteria, exclusive criteria. So he need to do deep down of all the futures from the CTRI. So what we have developed here is clinical trial match. So after entering all the patient reports and all the comorbidities, for example, exclusive criteria will be, we won't take hypertensive patient, we won't take CKD patient. These all the conditions will be. So after entering the patient details here, we can see the clinical trial match, which is actively recruiting in India as well as the actively recruiting in global. So here we can see few recruiting, non-recruiting clinical trials with respect to this patient. So here, this trial is not recruiting at the moment, but we can see a phase 2 study of anlotinib and platinum-based chemotherapy in patient with SMARCAC4 deficient locally advanced or metastatic lung carcinoma. And also we can see why this clinical trial is matches with the patient and investigations, primary endpoints, LGBT criteria, and inclusive exclusive criteria. So if a doctor have to register in this trial, so we also given as a contact option here. So here there will be like phases, first India as well as the global. And also for going for the global, we have all the options: China, Italy, Netherlands. If a patient is willing for go for the global clinical trial, you can see here. So this is one of the clinical trial future. And next, patient support manual. So let's think, a patient, he is diagnosed with some type of cancer. So we have to give patient support, like patient support manual for the patient, like what dietary recommendation have to take and what medications he is gone going, and we have to discuss what cancer he'll be having and what will be the stages and what support will be needed. So here we have made a customized, precision-based a patient support manual for the patient. So after uploading all the information here, if we click this patient support button, here we can click the languages. English, Hindi, Bangla, Telugu, Tamil, Malayalam, whatever languages we can upload here. And if we generate here, we will get within 2 to 3 minutes of whole patient support material. And also, why this patient support manual is very liked by the oncologist, because so most of the patients sometimes they'll be traveling from Chennai to Delhi for treating some type of cancer. So in dietary recommendation, we can't suggest to eat rajma or any chawal or Delhi-based foods. So because he's from Chennai, so in Chennai the food will be totally different, like idli, dosa, etc. So now when we enter the location as a Chennai, we will get customized dietary recommendation of this patient. So this is another beautiful feature in OneRx we have. So this is about my patient section. Now I will show you discover page. So think this is as a newspaper reading. So there'll be like many molecules get in FDA get updated on daily basis. So yesterday also we got one FDA drug molecule update. So let us keep as a 1 month. So now I got whole FDA drug molecules updates, whole clinical trial updates. So any information with respect to the oncology, everything in one page. So this is as the newspaper reading of oncology and stories. So here, many doctors have given feedback to us, like if any new research paper in oncology is get published, so can we see in an ONRX? So we have made for oncologists. So you can see here the July 24, 2026 today. So one of the paper got published. If you click this, it will directly go for the format section as well as the direct official literature page paper. And also we can see all the nature sources, PubMed, FDA, and Europe PubMed. And when it comes to clinical trial and patient support manual, so here we have entered already in the case here. So we have already a button, clinical trial button as well as a patient support manual button. So if we click this, we can get this clinical trial information here itself in Ask Feature. And also I need to highlight another feature here, notification. So you no need to get wait for any new FDA drug up information, any NCCN get information, any ESMO information, or else any conference information. So suppose you are in South India, you are unable to go for any conference in happening in Delhi or any Bhopal. So we will do live conference from the conference from live conference updates from the conference. So here you can see here previously we have done best of ASCO and Fortis Cancer Summit. All the conference updates you will be getting notified here. So these are all the onco-related features we are having. So you can use on daily basis. It's at no cost. So any questions from the doctors?
So I think if there are no questions, I think can we close the meeting if there are no questions?
Sure. And thank you for all joining today, doctors, and also thank you, Dr. Rajesh, for giving this wonderful.
Before closing, I will request you to please once again tell how to get this app and how they can use it for free, and then probably we can close. Can it be downloaded from the Play Store or maybe on the if you're using desktop, can you use it on desktop? Please, and then probably I think you can answer that also.
So this is the QR code. You can scan this QR code. So OneRx is available both web as well as mobile-based option. And
Dr. Anish, you'll have to share
There's
your
no
screen.
because QR code is not visible. It was there in the first slide, no, which we
Yeah, it was
started.
there in the first slide.
Yeah.
So as Dr. Anish comes up with the QR code, hi, good evening, everybody. This is Vivek. I am one of the founders of OneRx. We are keeping it free for all of the doctors over here. And this is for 1 year, that is correct. And even subsequently, we intend keeping it free. Our overall business model is anchored on getting pharma to sponsor it for all the doctors. But we are in early stages and we are going to see how it works out. So hopefully it's going to be free for doctors to use it every day, build more evidence-based treatment lines, get help, reduce the research work time that they take. In our precision AI study, we found that on an average, doctors reduce their research time from 7 minutes down to less than 1 minute. So it helps us in that way. It increases the confidence by 1.69 on a scale of 5. So before 1RX, the confidence of answers were uh, 2.88. And post 1RX, the confidence in the answers went up to approximately 4.59. So in that sense, it helps. Please download this product. You have it on App Store, you have it on Play Store, you can use it on the web. Use the refer code RP01. This will make the product free for you. Use it actively, prompt around 5 times in a day or so. See the quality of the answers that you get. I, Dr. Hanish, and our entire team is available for you. If you have any questions, just email us, just WhatsApp us, and we will be very happy to work with you on this. This is a made in India product. It's completely built within our country. It is completely compliant with DPDP Act. We have gone for a CDSCO test license approval, which should be coming within a week or so, making us perhaps the only platform in this country to have that kind of a medical grade approval.
Yes, sir. It's very reassuring that our data is not going anywhere out of the country. So
Correct, sir. Absolutely, sir.
So there is a question here. So what if patient get this? Can't they use it and easily find all treatment options? Just it out. So we are not giving this platform for the patients. It is only for the doctors. So we will take a say registration number and we will verify whether this user is the doctor or not. If any external general people will get installed, we will block them.
Yeah. So when you get in, please make sure you enter your MCI ID. Otherwise, you'll get those pesky, irritating calls from our sides. You'll get some pop-ups from the app as well. Just enter your MCI or any of your medical numbers so that we know that it is you and the platform will work uninterrupted in that case. Excellent. With this, Dr. Hanish, maybe wrap it up.
So if you have any questions, you can ping me to my WhatsApp. I'll be answer to your questions. And with this, we come to the end of today's evidence rounds. So on behalf of all entire team of OneRx, I sincerely thank our esteemed faculty, Dr. Rajesh, and for sharing your valuable time, clinical insights, and real-world perspectives. Thank you once again. We look forward to see you in upcoming evidence rounds. So evidence rounds will be conducting on every month, every week. You can join on every week. Thank you, everyone. Have a good night.